Today is newly diagnosed with myelofibrosis. Key things to know. This topic was selected because getting a diagnosis can often be overwhelming, and we hope that this webinar helps make things just a little bit easier to understand. And our guest speaker for today is Dr. Alexander Coltoff. Dr. Coltoff is a hematologist oncologist at the Medical University of South Carolina, and he is a specialist for MPN, so myeloproliferative neoplasms such as myelofibrosis, as well as acute myeloid leukemia and myelodysplastic syndromes. He's been published as a clinical investigator, as well as received an ASH, which is the American Society of Hematology Award for developing research scientists. I'm so happy that you're able to join us today, Dr. Koltoff, and I'll go ahead and turn things over to you.
All right, thank you, Dalton, and thank you to HealthTree for having me, and thank you everyone for being here to hopefully learn a little bit more about what myelofibrosis is and get a kind of rapid fire overview. Let me see if I can share this right. Okay. Dalton, just let me know if this is not working, but unless I hear otherwise, I'm going to assume it is. So
Looks great.
Okay, great. So hi, everyone. Like Dalton said, my name is Alexander Coltoff. I am currently at the Medical University of South Carolina in Charleston. As a little background about myself, I'm from New York. I completed my medical training throughout the city at Sinai and Columbia. And then I now am in South Carolina, where I primarily see people living with MPNs and serve as the lead investigator at MUSC for multiple clinical trials in this area. So I'm going to spend 30 minutes today talking about kind of the overview of myelofibrosis and what I think you need to know if you or a loved one were diagnosed with myelofibrosis in the recent past. The kind of overview of the talk, we'll talk about what is myelofibrosis, on a grand scale. What are the signs and symptoms? How is it diagnosed? If I was diagnosed, what does that mean? What were the criteria that were used to make that determination? What kind of doctor you should see if you were diagnosed with myelofibrosis, and then a kind of early look into what the treatment options are without getting too bogged down into any specific one. So really kind of like bringing it back, what is myelofibrosis? What does that mean? Because it's kind of a confusing word. So myelofibrosis essentially is a replacement of your normal healthy bone marrow with scar tissue. This is important because your bone marrow is the primary kind of site for blood cell production in your body. So the bone marrow is this kind of rich kind of center of your bones. It's a little bit less hard. It's not what you think about as your kind of, when you think about broken bone, or when you think about that nice white bone that it's in cartoons with dogs eating. The marrow is a little different. That's kind of the inner part of the bones, and that's very vascular. There's a lot of blood vessels there, and that's where your blood cells are made. It's all throughout your body, but the most kind of active sites of blood cell production are in places like your hips, which is where bone marrow biopsies are usually done, as well as places like your ribs or your backbones, which are obviously less safe for biopsies. You have three types of normal blood cells. You have red blood cells, which deliver oxygen to your body. You have platelets, which help you to stop bleeding. And you have white blood cells that are involved in the immune response and help protect your body from foreign invaders. With your normal bone marrow, you don't have to remember all these terms. It's a little bit, I think, complicated. But on the left side here, you can see this kind of normal, healthy-looking schematic of a bone marrow, where there's a lot of space for these blood cells, which are relatively immature, to kind of grow up and mature into their normal functional cells so that they can get released into your bloodstream and do their job. With myelofibrosis, we have here a deposition of these kind of long strings, which represent this material known as either reticulin or collagen. And essentially, both of those materials form what we think about as scar tissue. And so it's not really depicted here. I mean, you have the normal amount of blood cells here versus there. But in reality, a lot of these blood cells on your left, your monocytes, or this large blood cell is called megakaryocyte, space for them to grow up becomes limited, and they get pushed out, and they aren't able to mature normally in the bone marrow. And because you have an increased amount of this scar tissue and less room for healthy blood cells, you're able to make less blood cells, and that's a major consequence of myelofibrosis. Why does this happen? Again, without getting too much into the weeds of it, over 90% of people who are diagnosed with myelofibrosis will be found to have a gene mutation in one of three key genes, either JAK2, JAK2, which is the most common one, or less commonly in CALR or MPL. And through different mechanisms, these three genes, when they are mutated, they cause your cells to grow more quickly and without checks and balances compared to the normal state. And eventually, over time, this kind of disordered increase in cell production kind of burns out the bone marrow and leads to increased levels of inflammation and then eventually scar tissue forming in the bone marrow. These mutations or these genes normally act as kind of light switches, and they turn on when you need blood cells and they turn off when you don't need blood cells. And you can think about these mutations as essentially just keeping this light switch on and causing the body to be in a kind of hyperactive overdrive where they're constantly making new things. Like I said, if you've been diagnosed or a loved one's been diagnosed with myelofibrosis, there's a good chance that you have one of these three genes mutated. There's about 5 or 10% of people, which we call triple negative, who don't have a mutation in CALR, MPL, or JAK2. But those people, as well as these people with, CALR, MPL, or JAK2, will also have usual mutations in other genes that are thought to kind of also promote myelofibrosis. It should be noted that if you've been diagnosed with myelofibrosis and you have a mutation in these genes, you don't have this mutation in all of your cells. They're not in your healthy blood cells. They're not in your skin cells, your hair cells. They can't be passed down to children or through families. These are mutations that happen spontaneously as you got older that only affect the white blood cells affected by myelofibrosis. They're not affecting every cell in your body. What are the signs and symptoms of myelofibrosis? This is really important. So, I think there's three kind of main components of symptoms to myelofibrosis. One component comes from an enlarged spleen. So the spleen is an organ that sits kind of in the left side of your stomach. The spleen is one of those places in your body that can help take over blood cell production when the bone marrow is kind of scarred over and can't make the blood cells that you need. And because the spleen starts to make more blood cells, it can start to get bigger. And people with myelofibrosis can have spleens that are 2 or 3 times the normal size as before they had myelofibrosis. And so there's limited room in your stomach, in your abdomen to house all these organs like your spleen, your liver, your stomach, your intestines. And so if the spleen starts growing rapidly, it can kind of take up space there and push on the stomach and other organs, and that can decrease your appetite, can make you feel full easily, can cause weight loss, stomach pain. So that's one major kind of source of symptoms for people with myelofibrosis. Another major source of symptoms is low blood counts. So like I said, the normal bone marrow is less able to make blood cells, and that causes your blood counts to be lower. So low platelets can cause easy bruising or bleeding. That's known as thrombocytopenia. Low red blood cells, which is known as anemia, can cause symptoms like dizziness or fatigue or shortness of breath. And then white blood cells can be high or low with myelofibrosis, but when they're low, that can cause symptoms of frequent or recurrent infections. So things like fevers or getting viral infections or colds more frequently can happen. And then finally, what can sometimes be the most bothersome group of symptoms are what's known as constitutional symptoms. So constitutional symptoms are similar to symptoms that you can get, when you have, let's say, the flu or COVID. Those are symptoms of just feeling fatigued and worn out. They might include night sweats. They might include weight loss despite having a good appetite, bone pain, difficulty kind of concentrating, something known as brain fog. These can be very prevalent with myelofibrosis and are harder to kind of explain eloquently. But, to make a long story short, myelofibrosis causes a lot of increased inflammation in the body. And a lot of these symptoms result from the increased levels of inflammation with myelofibrosis. This is kind of restating what I just said. But again, low white blood cells can cause an increased risk of serious infections. And when I think about blood cancers that I treat in general, be it myelofibrosis, more aggressive blood cancers like acute leukemia, less aggressive blood cancers like myelodysplastic syndrome, really one of the main reasons that they're dangerous is that low white blood counts can predispose to serious infections. So this is a very serious thing to happen with myelofibrosis. And then again, just to kind of see it written out there, symptoms of anemia include fatigue, dizziness, chest pain, shortness of breath. And then symptoms of low platelets include things like easy bruising and bleeding. And this is bleeding or bruising that should not happen during normal activities like brushing your teeth, let's say, or a scratch that fails to kind of, heal quickly. Constitutional symptoms, again, like we discussed, refer to these kind of non-specific symptoms that I really think about as having, kind of symptoms similar to a flu that won't go away or a cold that won't go away. Just feeling like you're not able to get things done, kind of just feeling bleh, trouble concentrating, not being interested in things you're normally interested in. Those can all happen due to, increased levels of inflammation and just chemical imbalances from the cancer. So those are the symptoms. The symptoms kind of go into the risks with myelofibrosis. So the main risks with myelofibrosis are from the symptoms. So, low energy, low appetite can lead to weight loss and loss of kind of muscle mass, etc. The most common and the most kind of dangerous complication of myelofibrosis is that over time, you can experience progression of your myelofibrosis to acute leukemia. This doesn't happen in everyone. It probably happens in about 20 to 30% of people living with myelofibrosis. And it typically happens over the course of years or decades. But it happens in enough people. And when it does happen, it's dangerous enough that it is the leading cause of death in people with myelofibrosis. Other causes of death in people with myelofibrosis include heart disease. And that's due to a number of factors, including the inflammation that results from this. And so it's really important to keep an eye on things like cholesterol and diabetes and make sure those things are managed appropriately. And then the last kind of, few things here relate to the low blood counts we talked about. So infections are common and that can happen, especially if your white blood cell count is low. Bleeding events can be dangerous, especially as those platelets fall below levels of 10 or 20,000. And, bleeding through the skin or on your gums is not very dangerous, but when that bleeding occurs, let's say in the stomach or God forbid in the brain, that can be really dangerous. And then, as you can experience weight loss and loss of energy and loss of kind of strength. Things like accidents or falls can be more dangerous if you're not able to be kind of, recover from them as quickly as you once were. How do we diagnose myelofibrosis? So myelofibrosis can occur either kind of randomly without a predisposing condition. We call that de novo, or kind of nothing, from the Latin term, or it can happen after another similar condition, all of which are known as myeloproliferative neoplasms, or MPNs. So you have your less aggressive, more indolent myeloproliferative neoplasms, and those are classically referred to as ET, or essential thrombocythemia. This is a condition where you make too many platelets. Or PV, or polycythemia vera. This is a condition where you make too many red blood cells. And both of these are fairly chronic, less aggressive conditions that over time can turn into myelofibrosis in a subset of people. And it occurs differently in both conditions. So I usually tell someone with ET that their chance of developing myelofibrosis is about 5 or 10% at about 2 decades after diagnosis, whereas the chance of developing myelofibrosis for someone with PV is about 10 or 20% after a few decades of having it. And in general, the myelofibrosis that develops after these conditions is not necessarily more or less aggressive than if it arose out of nowhere. It can present a little bit differently, but we treat them all pretty similarly. And these things can switch between each other as well, but that's less relevant to today's talk. If you have been diagnosed with myelofibrosis, then you really should have had a bone marrow biopsy done. If you haven't had a bone marrow biopsy done, then you need to ask why not, and you have to kind of question if you've been diagnosed with the right condition. So seeing that scar tissue in the bone marrow and seeing some other characteristic changes of the bone marrow is really needed for diagnosis. A bone marrow biopsy is an outpatient procedure. It's done either in the clinic or with the interventional radiologist. When I do it in clinic, I do some local anesthesia, kind of like the same stuff that you get at a dentist's office, called lidocaine and novocaine. We do some anesthesia around the site that we're going to do the biopsy at. And then the biopsy itself takes about 15 or 20 minutes. You lie on your back for about 15 or 20 minutes, and then you can drive home the same day. And I have people who even return to work the same day. So it's an outpatient procedure. There can be some discomfort associated with it and some soreness afterwards, but it is not something like a minor surgery or even a major surgery. It's a relatively well-tolerated procedure. And it's done at the bedside typically, and again, with this needle here to get a little bit of the bone marrow and a little bit of the blood inside the bone marrow. In addition to a bone marrow biopsy, you should have some basic blood work, a complete blood count or CBC to check on the levels of things like red blood cells, white blood cells, and platelets is important. You should get a metabolic panel that looks for electrolytes, liver function, and kidney function that can help determine what treatment is the safest and best for you. And then, like I said, because heart disease is the second leading cause of death in myelofibrosis, checking things like cholesterol, your lipid panel, HbA1c, which is a test for diabetes, are all important kind of other tests to risk stratify your myelofibrosis. A bone marrow biopsy needs to demonstrate scar tissue, but there's other things that are really important, especially in 2025, for knowing what the best treatment for you is. And these include things like genetic testing or testing for chromosome changes. And one common thing I see and people refer to me is that they've had testing for either JAK2, CALR, or MPL, those kind of 3 driver mutations, but they haven't had an extended panel test for other mutations that can throw you into a higher or lower risk category. And so it's really important that your doctor sends for not just those 3 mutations, but a full panel of at least 40 or 50 different genes that can be mutated with myelofibrosis and can affect the treatment you get. Imaging tests to look for that large spleen we talked about, or even a large liver, are sometimes important to get in people with myelofibrosis. We can sometimes feel the spleen on our physical exam, but if we can't, or if we want a very accurate number for how large the spleen is, then a non-invasive test like an ultrasound that doesn't even use radio labeled dye and that's done without any IVs can be very safe and easy. And then if you're younger, and by that I mean younger than age 75 or even 80, but really 75, 76 is kind of the upper limit for bone marrow transplants. Your doctor might want to send some testing to see if you would be a good candidate or not. We could talk about that a little bit later too. This is just to kind of show everyone that there is standard criteria for diagnosing myelofibrosis. There's 2 criteria sets. One is by the WHO, or World Health Organization. Another one is by a group known as the ICC, and they're very similar. But there are kind of objective diagnostic criteria that we use to diagnose myelofibrosis. And honestly, we've talked about a lot of them so far during this talk. So we need to see fibrosis, which is the scar tissue. And that's why I said a bone marrow biopsy is really important. We need to see that there's one of these 3 mutations or another clonal marker, meaning another mutation present. And we have to make sure that, there's no other blood cancer or blood condition that can explain what we're seeing. And that's really kind of the hallmarks of myelofibrosis. This is probably more for a physician talk, but just to let everyone know, there are other reasons why you can have scar tissue in your bone marrow. Things like chronic infections, like certain fungi or tuberculosis can cause scar tissue in the bone marrow. Certain treatments that you may have gotten for other conditions, like radiation, can cause scar tissue in the bone marrow. Certain autoimmune conditions are really important to be aware of, like lupus or rheumatoid arthritis. And really a key thing that I do when I see someone who may have myelofibrosis is make sure that they don't have an autoimmune condition, especially if they don't have like that JAK2 mutation or something. And then probably the most important one is making sure that there's not another blood cancer that can explain this. So some other blood cancers can cause So low levels of scar tissue in the bone marrow, and we can treat those cancers completely differently. And that will go into kind of what doctors you should see when you're diagnosed with myelofibrosis. A common question that I get from everyone is, what stage am I? Am I 1, 2, 3, 4? And a lot of blood cancers, including myelofibrosis, are not staged like other cancers, like lung cancer or colon cancer, where if it's stage 1, we can do surgery. If it's stage 4, then you need chemo. In general, your bone marrow is everywhere throughout your body. And so we don't do 1, 2, 3, 4. Instead, we kind of try and tell you how risky or not risky your myelofibrosis is. And by risk, we mean kind of the risk of passing away from myelofibrosis or the risk of your myelofibrosis becoming acute leukemia. And we use different different numbers and different data to make that assessment, including, blood counts, the degree of scar tissue in the bone marrow, and then really importantly, the presence or absence of other mutations, which is why making sure your doctor sends a panel of genes, not just those 3 genes, is key to accurately kind of diagnosing and really, our version of staging for myelofibrosis. Once you receive the diagnosis, I think, one of the first things I would do is see kind of what support groups are out there. And that can mean family, friends, loved ones, acquaintances, people who may have had myelofibrosis in the past. There's also really, really good, I think myelofibrosis, more so than most other cancers, is a really good network of kind of like patient-centered resources for it. So these are just a few of them: the MPN Research Foundation, the Leukemia Lymphoma Society, HealthTree. There's other ones as well, but they have a lot of kind of like patient language, not like doctor or physician language, like reading that you can look at. And they also kind of organize things like this where you can talk with physicians or talk with other people going through it to kind of see what's helped other people in your situation. I think everyone, and I'm a little biased here, but I think everyone who has a diagnosis of myelofibrosis should at least one time see a specialist like myself to get a second opinion, or just make sure that your treatment is kind of up to date for 2025. The reason I say this is because these are rare conditions, as opposed to breast cancer, lung cancer, where a general oncologist may see hundreds of those cases a year. A general oncologist is probably only seeing 1 to 2 patients with myelofibrosis a year. And so, understandably, they're not attuned to the newest updates and the newest advances in myelofibrosis. They also probably don't have access to clinical trials that we have at major medical centers like MUSC, for example, or like, other referral centers. And, even if I'm seeing someone who lives 2 or 3 hours away, I can still keep in touch with them and see them by video or phone call once or twice a year. And that way you always have someone kind of in your corner who's a specialist in this disease and can help guide your treatment from afar and just kind of make sure things are being done correctly. It's also really important, I think, to see someone like myself early on, because if you are potentially a candidate for a bone marrow transplant, that is the only curative treatment for this. And bone marrow transplants become less doable the longer you live with the disease and the older you get. And so, unfortunately, this is something I've actually seen not uncommonly, where someone won't get referred to me until they've been diagnosed with myelofibrosis for 5 or 10 years. And by the time they reach me, their disease has progressed or they've gotten too sick to get a bone marrow transplant. And if they had seen a specialist early on in their disease, they might have gotten a bone marrow transplant and they might have been cured. So never hesitate to ask for a second opinion. Any doctor who's uncomfortable with that is not the greatest doctor. We should all be comfortable with you seeing a specialist. It's not a competition. We just want what's best for you. And definitely just ask your doctor, hey, how many people like me do you see a year? If you don't see a lot of cases of this, who's some specialist that you trust in, the general radius who would see me? I think that's the most important thing for today, honestly. Yep, go back. So quickly, we can talk about treatments, and this could be a whole 2-hour talk. But it's really important to know that, myelofibrosis is an extremely heterogeneous disease, meaning that there's a ton of different presentations and a ton of different kind of outcomes that can happen. I have people who I treat for myelofibrosis who have been watching without treatment for 5 years. And then I have people with myelofibrosis who need to get admitted to the hospital the next day for chemotherapy, and everywhere in between. So, some factors that you should take into account, or your doctor will take into account, include your age, how aggressive your myelofibrosis is. So we talked about like those risk scores that we have, not necessarily staging. Your symptoms. People with more symptoms from myelofibrosis should get treated more quickly than people without symptoms. Other health conditions that may affect how safe the treatments are for you. And then probably most importantly, your values. Oftentimes, almost always, there will be more than one appropriate treatment course that I think is reasonable. And it's kind of up to me and you and deciding, what part of the treatment you really value. Is it like more quality time at home? Is it, the best chance to go into remission? Is it this? Is it that? That will help us decide between the different treatment options. A lot of people, or a decent amount of people, don't need to do anything when they're diagnosed with myelofibrosis. This is more common for certain less aggressive blood cancers, but myelofibrosis certainly has its kind of presentations that don't warrant treatment. If you're, not having many symptoms, if you don't have any high risk DNA mutations, if you don't, need a bone marrow transplant, you don't necessarily need to get treatment. I've got people, like I said, who I will see, 3 or 4 times a year. And during those visits, we'll make sure there's no new symptoms. We'll make sure they don't have any, significant weight loss or energy change. We'll do a complete blood count check and make sure there's no new low blood counts. And if there's not, we can just watch and, and wait, because any treatment we do have always has a side effect. There's no treatment you'll ever get that is completely safe. And so it's always kind of a risk-benefit analysis. That being said, there are some benefits to starting treatment earlier. And it's important to kind of talk about these with your doctor and see, if you're a good candidate to start treatment earlier. So there's kind of a snowball effect that I think about with myelofibrosis, where to a certain point, treatments may be more effective before a lot of scar tissue develops or before that spleen gets really, really big. And, at some point we might kind of be behind the 8 ball, and we might let the myelofibrosis accelerate too much to where the treatments start being less effective. So I think it's really important that if you are kind of in that watch and wait approach, which I think is appropriate, that you're seeing a doctor at least, probably 2 or 3 times a year, so you don't kind of miss your opportunity to intervene when the treatments still have their maximum effectiveness. Treatments can look like a lot for myelofibrosis. So at the most basic, we have kind of what we call supportive care. And this can include things like blood or platelet transfusions. If your red blood cells or your platelets go very low, there's no real white blood cell transfusion. And so sometimes a low white blood cell count will kind of, need more aggressive treatment. If the white blood cell count is low, then your doctor may recommend preventative antibiotics, things that can prevent bacterial, fungal, or viral infections. These are not 100% effective at preventing infections, but they can reduce the chance of it. And then, like I said, heart health is really big for myelofibrosis. So managing other things like stopping smoking, starting a good exercise regimen, weight loss, that's, a safe amount, lose too much weight with myelofibrosis, et cetera, to just kind of protect the heart as much as possible. And then finally, medications. These are probably what people think about more when thinking about treatment for cancer. So there are medications that kind of just improve blood counts. And then there are medications that may or may not kind of affect the actual cancer course. And even though it's controversial, they may kind of improve survival with myelofibrosis. And those are what we call JAK inhibitors. So the medications that can improve blood counts are things that are generally just aimed at improving the red blood cells and occasionally the platelets. But all of these things like Aranesp or Procrit, these are growth factors. These are the same things that like Lance Armstrong used to dope in the Tour de France, is what I tell people. These are kind of synthetic versions of the hormones your body makes naturally. Those are injections. The one at the bottom, luspatercept, also known as Reblozyl, similar thing, helps boost up your red blood cells. And that's for a little bit more experimental in 2025. Danazol is a steroid that can also boost up your red blood cells. Revlimid is a type of chemotherapy that can boost up your red blood cells, but can lower your other blood counts at the same time. And then hydroxyurea kind of does the opposite of what these other ones do. It's a old school chemotherapy that's very well tolerated and can kind of reduce white blood cells and sometimes shrink the spleen marginally as well. If you have a higher risk version of myelofibrosis, or if your symptoms are very bothersome, then JAK inhibitors are probably the best treatment for you. So JAK inhibitors, if you think back to the early part of this talk, JAK inhibitors kind of turn off that light switch that's turned on all the time with myelofibrosis. And we have 4 of them now. Ruxolitinib or Jakafi was the first one approved in 2011. And since then, we've had 3 additional ones in Inrebec, Vonjo, and Ojjaara. They've gotten increasingly more difficult to spell as they've gotten approved. But they all have their slight differences. And the nice thing about the newer ones, which are Vonjo and Ojjaara, is that they can help boost up the red blood cells instead of lowering them like the older ones do. But the older ones, like Jakafi and Inrebec, can probably do a better job of reducing the spleen when it's very large and may have a more potent effect than the newer ones. So each of them kind of has their place and their own little side effects. And it's something that you'll talk with your doctor about, and it's important to take into account your other health conditions and your blood counts when making a decision about JAK inhibitors. JAK inhibitors are all oral, so they're all pills. They're all taken once or twice a day. And they all take 3 to 6 months really to see their maximum effect. So they're all good options. They have, different roles depending on what your blood counts are. And just because you didn't do well with one doesn't mean you shouldn't try another. So they all have some evidence in the second or third line, as we say, after one has already not worked, or you've, had success with one but are ready for something else. Clinical trials, I think, should be considered for every person with myelofibrosis. We're constantly trying to improve on what's currently available. And really what I showed you here, this is what we have, so anything we can do to add on to that is a benefit. So clinical trials are always a recommended, thing for me. They're not right for everyone. There's certain questions you should ask your doctor who's running the clinical trial to know if they're right for you. Do you have something specific for me? Because certain clinical trials may only be appropriate for people with low risk myelofibrosis. Some may be only appropriate for high risk myelofibrosis, etc. When thinking about a clinical trial, you should think about if it works for you logistically. So oftentimes clinical trials require more visits, more blood work, and more of a commitment on your part. They will sometimes give you some remuneration for that, meaning like a stipend, or they'll pay for visits or give you some kind of money to compensate you for your time. But it might be tough for you to go 2 hours back and forth if it's not in your area. At the same time, they might offer some housing or some lodging for those clinic visits. So that's an important thing to consider. And then kind of along with that, what resources are available. So is there transport? Is there lodging? Is there, are the drugs in the clinical trial covered by the company running it? Things like that are really important to ask. And then there's a lot of different ways to find clinical trials. I think the best way is to see a specialist because they're kind of aware of what trials are available in their area. But support groups run through organizations like HealthTree or MPN Research Foundation can sometimes put you in touch with clinical trials in your area. And then if you're really kind of like to do your own homework and research, the website clinicaltrials.gov has every single available clinical trial for every single condition known to man on it. So you just have to kind of type in what's relevant to you, and you can search by location and kind of status of the trial and do your research that way. Quickly, I should mention the only cure for myelofibrosis is a bone marrow transplant. There's 2 types of bone marrow transplants. There's autologous, where you get your own stem cells, and there's allogeneic, where you get someone else's stem cells. It's important that if you're thinking about transplant, you should know that it's the allogeneic type. So it's someone else's stem cells that you get. And it's important because those transplants are a lot more involved and unfortunately risky than autologous transplants. So if you have a family member or a friend who's gone through a transplant and you want to know what it's like, make sure they got stem cells from someone else. That's really more appropriate situation. And because they're risky and they entail a lot of side effects, only about 10 or 20% of people with myelofibrosis end up getting a bone marrow transplant. But like I said, unfortunately, part of that is that people aren't referred early enough to a transplant center. So if you have myelofibrosis and you're under age 75, or really whatever your age is, you should see a specialist like myself at a transplant center. And especially if you're younger than age 75, make sure you ask your doctor, is a transplant right for me? Because it's the only thing that's going to potentially get rid of your myelofibrosis forever. This is too busy. We don't have to talk about it in detail, but on the left are the treatments I talked about, transfusions, these drugs that kind of improve your blood counts, JAK inhibitors. And then on the right, just to kind of show you that there is kind of active research being done, these are all things that are in late stage clinical trials, including, I think this figure was from like 2 or 3 years ago, and you can see that these drugs have already gotten approved. We have other drugs that have been in phase 3 trials that kind of, those are the last step before FDA approval if the drug is effective. And we have some other clinical trials going on as well. So in summary, myelofibrosis is a rare form of blood cancer that can have a very variable presentation. Some people have no symptoms at all and are diagnosed incidentally, while others have a large amount and distressing amount of symptoms that really affect your daily living and significantly impair your quality of life. In order to get an accurate diagnosis and in order to kind of get the best treatment for your specific situation, I recommend everyone sees an MPN specialist at least once during their treatment course to consider clinical trials, bone marrow transplant, and to really get a better understanding of their personal situation. And then the treatments for myelofibrosis are as varied as the presentations. And so, a lot of factors, including your blood counts, your other health conditions, your myelofibrosis situation, your doctor's opinions, your personal values should all be taken into account when making a treatment algorithm for you. With that, thank you for your time. This is my email address, like on my clinic phone, if you have any questions after this. But I'm happy to take any questions right now too.
Awesome. Thank you so much for that presentation. That was super, super informative. So now is the time for our questions. We have a couple in already, but just as a reminder, if you want to ask a question, just type it in the chat box there. So our first question, I'm going to generalize this a little bit, but if an individual is given the option of either taking, what is this, Aranesp or Ojara, which do you think is more, which do you tend to think the field is using for treatment more often now?
Yeah, I think it's an interesting question. Ojara is a JAK inhibitor, like we talked about. The generic name is momelotinib, and Aranesp is one of those kind of Lance Armstrong drugs I talked about that just are a synthetic version of your hormone that tells you to make more red blood cells. Ojara has a benefit also of improving blood counts. And so I think that's where this situation arises. If your red blood cells are low, should I go with a hormonal shot that improves my blood counts? Or should I try Ojara, which is a JAK inhibitor that can improve my blood counts as well? I would probably base it on your symptoms and your kind of risk level of myelofibrosis. So Aranesp being just a hormonal treatment is not going to do things like improve constitutional symptoms. It won't shrink your spleen. It won't potentially slow down the kind of timeline of your disease. It will just improve your blood counts. Versus Ojara, as a JAK inhibitor, can do all those things I talked about, like shrink your spleen, improve your symptoms. So if you have a higher risk version of myelofibrosis or you have other symptoms related to myelofibrosis, I would typically pick Ojara. At the same time, Ojara has more side effects than Aranesp. So if you do have baseline neuropathy, let's say, like numbness and tingling, that's something that Ojara can worsen. If you have issues with gastrointestinal side effects, like nausea, vomiting, diarrhea, that's something Ojara can worsen as well. So there's some pros and cons to each approach. But in general, I would say if your myelofibrosis is high risk or you have other symptoms besides just a low red blood cell count, I would probably favor Ojara in that situation.
I think that's a great answer. And that was a really good question because I've sat in on plenty of these webinars, and AirNest isn't one that I typically hear about. So it's nice to hear kind of all the different options that are available. Um, Quite a few of these that have come in so far are going to be related to anemia or hemoglobin. But the next question up is there anything to improve hemoglobin if your erythropoietin levels are too high to receive epoetin injection?
Yeah, that's a great question. That question gets at the fact, like I said, that EPO injections or ARNS injections are just synthetic versions of your natural hormone. And so if your natural hormone levels are already super high, giving you more is not going to help you. There's a lot of agents that have effectiveness in that situation. So again, looking at our not JAK inhibitors, things like luspatercept off-label can be helpful. And luspatercept has an approval for a similar blood cancer known as MDS, regardless of your EPO level. It's being studied in a phase 3 trial right now, known as the Independence trial, and it has good data in a phase 2 trial, either by itself or in combination with a JAK inhibitor. Things like danazol and Revlimid can also be helpful for your hemoglobin level, despite having a high EPO level. And then your newer JAK inhibitors, like Vonjo, like Ojara, essentially make more iron available to your blood cells, and that helps them create more of themselves and increase your hemoglobin. So really, almost all of our options can be effective in a setting of high EPO. It's really the Aranesp and Procreate that aren't. I will say, just to kind of keep expectations reasonable, and this is like something else I think your doctor should be very transparent with you about. People with higher EPO levels do tend to have a lower response to agents that improve their blood counts because your body's always already been trying to do it by itself. So yeah, I mean, any of these agents might be less effective in someone with a higher EPO level, but they're definitely worth a shot. And I have people who they're effective for regardless of their EPO level.
All right. Next up is another good one. What is the impact or significance of high ferritin levels in secondary myelofibrosis? Would dietary iron consumption increase ferritin levels, or is the high ferritin a result of myelofibrosis? What is regarded as an elevated ferritin level?
Yeah, all great question. So just remind me if I missed one, but ferritin is essentially kind of the storage form of iron in your body. So most of our iron is kind of bound up in either our white blood cells known as macrophages or in our liver or other organs. And when we need iron, our ferritin is released into our bloodstream, and when it's not, it's kept, packed up. Iron or ferritin levels can also be high in instances of inflammation, right? And so, people with myelofibrosis can have high ferritin levels for a number of reasons. One, if you've been getting a lot of blood transfusions, then each blood transfusion has a ton of iron in it, and your iron can start to accumulate that way. You can also have just increased inflammation with myelofibrosis, and that can increase your ferritin levels. I consider a high ferritin level, really anything above 100 or 300 is high, but I consider it a little bit more dangerous when it gets to above like 1,000 or 2,000. When it gets that high, like quadruple digits, it can start to deposit in your organs like your liver and your heart and start to impair the function of those organs. So I keep an eye out for that. The amount of iron that you take in through your diet is so low compared to the iron that you get in a blood transfusion or just in the iron that's being circulated through your body on a normal day that this is a frequent question I get. And I tell people, eat what you want. If you like red meat, if you like spinach, if you like kale, anything with high iron in it, I don't limit that at all because staying healthy, keeping your protein levels up, keeping your muscle mass up is way more important than going on a restrictive diet. One red blood cell transfusion has as much iron as you're going to absorb naturally in like 250 days or something like that. So So really, it's minimal the amount of dietary iron compared to the iron other sources. So eat what you want. I wouldn't worry about that so much.
Okay. And then next up, I think you covered this one a little bit earlier, but I think this individual may have missed that part of the talk. But is there any variance for progression to myelofibrosis from ET or primary myelofibrosis? What's a higher incidence rate, secondary or primary myelofibrosis here?
Yeah, they're pretty similar. If you take everyone, the cases of primary versus secondary myelofibrosis, it's about half and half. Within secondary myelofibrosis, more people with PV will develop myelofibrosis than ET. And we even have different risk scores for people with secondary versus primary myelofibrosis. But there's been some studies done that show that the scoring systems for primary myelofibrosis do a better job than the scoring systems for secondary myelofibrosis, even in people with secondary myelofibrosis. So in general, I treat them similarly and the same. And they really shouldn't affect your treatment options so much, depending on where your myelofibrosis came from.
All right. And then next up, we have another anemia question, but this one's asking about blood transfusion. So they're dealing with anemia, their doctor's recommending them blood transfusion. They want to know if there's any other options for them.
Yeah, I mean, any of the options we talked about, I think are reasonable, and I really prefer almost any option over blood transfusions for the reasons I talked about, right? Like every blood transfusion gives you a ton of iron. The more iron you get, the more it deposits in your organs. The more blood transfusions you get, the higher chance that you develop antibodies to additional blood transfusions. And blood transfusions can also cause allergic or anaphylactic reactions. So there's a lot of reasons to avoid blood transfusions. It's also just kind of a pain to be hooked up for 3 or 4 hours at a time for it. So there's JAK inhibitors that can improve your blood counts. There's non-JAK inhibitors like Aranesp, like luspatercept that can. And I think the best treatment for you depends on a number of factors that, kind of depend on your specific situation.
All right. And then these are probably going to be our last couple of questions here. Um, this one, they're asking, are there any meds that are currently targeting CALR?
Yeah, it's a good question. So CALR, like I talked about, is the second most common mutation in people with myelofibrosis. It affects about 30% of people with myelofibrosis. And CALR is interesting because it creates this mutant protein that is completely different from your regular protein, and it's only present on your bad myelofibrosis cells. So it's very targetable. And because of that, there's a number of kind of novel therapies that are being developed for this. None of them are FDA approved right now, so they have to be received through a clinical trial. But we have antibodies targeting that mutant protein. We have what are known as bispecifics, which is an antibody against the CALR, as well as a homing device that attracts your immune system. So the immune system can recognize the CALR and destroy it. And then we even have transplants specifically for myelofibrosis, known as CAR T cells, which you might have heard about in the news, that are approved for things like lymphoma, um, and some other solid cancers nowadays. And these are all being studied in mostly phase 1 trials. So these are early clinical trials that are being done to see if these therapies are safe. And if they are, the next step is to move into phase 2 and phase 3 clinical trials to see if they're effective or not. And if you have CALR mutant myelofibrosis, then like I said, you see a specialist or go on clinicaltrials.gov, you should be able to tell if there's a trial, in your area.
And just want to let people know if you are interested in learning more about CAR T therapy and the potential that it has for myelofibrosis, I'm actually in the works right now of recording a podcast for that. And I'd anticipate that be released sometime in the next month or two, probably, pretty early on in that process. But that is something that I'm working on. So if that's something that you're interested in, just want to let you know to keep your eyes out for that. All right. And then I'm going to go ahead and decide this one's going to be our last question, just because I think it's a really good one to talk about some of those other mutations that you mentioned earlier and how it can be really important to have more than just the basic MIPL, CALR, and JAK2. But are there any recent studies on second, they say second gen mutation, but just those secondary mutations and the risk of ET and PV progression to myelofibrosis. They're particularly interested in the SRSF2 and TEP mutations, but just where's the field at in kind of examining these secondary mutations?
Yeah, that's a great question. So, like I said, your CALR, JAK2, MPL mutations are what's known as your driver mutations. Those are the mutations that really are thought to kind of create the myelofibrosis situation. Sorry about my dog. And kind of drive the scar tissue formation in the bone marrow. But there's a host of other mutations that are all kind of alphabet soups like ASXL1, TET2, DMT3A, SRSF2, et cetera, that can kind of drive up your risk score with myelofibrosis. And these mutations can be seen with PV and ET as well. So there are a bunch of different risk scores for myelofibrosis. The one that I like the most, and I think that most people like, is known as the MIPS 70 score. This is the molecular inspired prognostic scoring system. And the molecular part of it refers to, the incorporation of these potential high-risk DNA mutations. Now, it's less commonly used, but there is the molecular inspired prognostic scoring system for ET and PV as well that were largely developed out of the Mayo Clinic. And SRSF2 is included, at least for PV, I believe, but I have to admit it's not something that is as widely used in 2025 as it is for myelofibrosis, mostly because those conditions have a lower chance of developing something aggressive. And so some doctors may not be as familiar with the MIPS ET or PV as they are with the MIPS for myelofibrosis. But I think it's certainly a worthwhile thing to calculate, for your doctor to do if you do have PV or ET and you have those extra data for your genetic situation. And again, it really goes back to the point that Dalton brought up again, that I brought up twice during my talk, which is that, if you just know you have JAK2 positive myelofibrosis, and that's all you might think you're in a low risk situation. But if you also have an IDH mutation and a U2AF1 mutation, for example, then that might throw your situation to a higher risk situation. And we might go from recommending surveillance or a JAK inhibitor to recommending a bone marrow transplant for you. And if we don't know that until, let's say, 10 years after you're diagnosed, we might have missed our chance to intervene on it. And that's a really unfortunate situation. And it's really why it's important to get a comprehensive genetic and molecular profiling for your situation the second you're diagnosed.
Yeah, I think that was beautifully said. The more information that you can get your doctor, the better they're going to be able to treat you. So while knowing that you may have a JAK mutation is great, really asking about, can I get more extensive genetic testing, I think really does make a huge difference in the types of therapy that you'll receive and the quality of that. So we're going to go ahead and close out our question section because we are at the end of time here. But thank you, Dr. Koltoff. That was wonderful. Both your presentation and your answering of the questions was fantastic. So thank you so much for joining us today.
Yeah, thanks again for having me, Dalton. Thanks everyone for being here. And I think Dalton, I sent you my slides with my email on the last
Yep,
slide. So if there's any questions I couldn't get to today, feel free to email me and I'll be sure to respond.
perfect. All right. And then as everyone leaves today, I just want to let you know that we have a couple of upcoming webinars. On April 24th, we're going to be talking about what is integrative oncology for myelofibrosis. This will be with Dr. Christina Galwin. Dr. Galwin is a MPN specialist as well as an integrative oncologist. So that will be a really interesting one if you want to learn a little bit more about how alternative medicine and traditional medicine can fit together for your treatment. And then on April 30th, we're going to be talking about MPN and cardiac health. And this is actually going to be a really cool one with a cardiologist who has done research in this field. So they are a cardiologist who has done a lot of research for MPN and heart health. So both of those are really exciting ones. And if you're interested, I encourage you to register for them. And then as you leave today, I want to let you know again about the short survey that we have. It really does help when trying to come up with topics if I can hear what you guys are interested in. So if you'd take a moment to complete that, I would really appreciate it. And then finally, I just want to say thank you to everyone today. Thank you to Dr. Koltoff for your presentation and staying on and answering questions. Thank you to everyone in the audience for joining us and helping build our myelofibrosis community here at HealthTree. I've gone ahead and I've included my email on this slide, so please feel free to reach out to me if you have any questions about HealthTree or any of our programs. I'm always happy to help or even just chat with you. I truly appreciate each and every one of you, and I hope you have a wonderful rest of your day.